A very warm good evening and warm welcome to all our audience and our renowned speakers. I, Dr. Vaishali Une, welcome you all on behalf of Aurangabad Ophthalmic Association, and I do thank the MOS team, President Dr. Parikshit Gopte, Secretary Dr. Shirish Thorat, and Ragini Ma'am, Secretary, Scientific Committee, for allowing us with this webinar. With the temperature warming up and dry eye setting in, I thought that this is the right time for the webinar based on dry eye disease. So I now hand over to Parikshit sir for the next agenda. Thank you.
Thank you, Professor Vaishali. Yes, dry eye is literally a hot topic nowadays, not just because of the temperature, but because we see so many patients in our OPD, in a private OPD, perhaps 10 to 20% of patients who come have dry eye. And there is so much of research that has happened. There are so many recent advances. So I congratulate the Aurangabad Ophthalmology Association for thinking of this and taking up this very, very, what shall we say, a topic that is very important for this season and this time. So without much ado, I will again hand this over back to Professor Une, Professor Ragini Parikh, and the scientific committee of MOS, who is usually the brainchild in designing these webinars with each district. And Aurangabad, of course, is a very special district, and it has a lot of, I think this is the third one that we are doing with them in the past 4 months. So we again look forward to another intellectual treat from them. So back to you, Professor Une.
Thank you, sir. Thank you so much. I now request Dr. Arun Architre to please introduce our speaker, Dr. Varsha Nandedkar, ma'am.
Thank you, madam. Now, the first speaker for today's session is Dr. Varsha Nandedkar, madam, who will speak on overview of clinical feature of dry eyes. She is currently working as professor and head of the department at GMC Aurangabad. She is gold medalist for MS Ophthalmology. She has presented many papers in national and international conferences and received Best Paper and Poster Presentation Award. She was the chairman scientific committee for MOSCON 2018. Now, I request ma'am to continue the session. Varsha, ma'am.
Ma'am, please share your screen.
Yeah. Everyone. First of all, I'm thankful to organizers for giving me the opportunity to speak on this topic of overview of clinical features of dry eye. Dry eye is a major public health problem affecting millions of people across the world. It is a symptomatic disease causing significant discomfort and substantially affect the sufferer's quality of life. In India, its prevalence ranges between 9.6% to 63.6% as per various studies conducted in northern and eastern India. Let's know a few things about tear film. All of us know that tear film consists of outermost lipid layer secreted by meibomian glands and Zeiss glands, middle aqueous layer secreted by main and accessory lacrimal glands, and innermost mucin layer secreted by goblet cells of conjunctiva. Mucin layer converts hydrophobic corneal epithelium into hydrophilic epithelium over which tear film stays. As per new guidelines, there are only two layers, outermost lipid layer and inner mucin aqueous layer. Tear film provides smooth optical surface by tackling the fine irregularities on ocular surface and forming the crisp, clear, sharp retinal image. It helps mechanically by cleansing out the irritants and foreign material and lubricates the surface. It provides nutrition to cornea by supplying the atmospheric oxygen, and it has the antibacterial properties due to presence of lactoferrin, lysozyme, and immunoglobulin A. So this is the lacrimal function unit for smooth functioning of tear film. It consists of mainly two structures. First one is the ocular surface and second is the lacrimal gland. Ocular surface communicates with lacrimal gland via fifth nerve as afferent through brainstem and efferent as the seventh nerve, which supplies lacrimal gland and results in tear secretion. Ocular surface consists of conjunctival epithelium, corneal epithelium, goblet cells, lids, and lashes. So the smooth functioning of each component of this lacrimal function unit is responsible for creation of stable tear film. Any dysfunction of any of its component will result in unstable tear film and dry eye. So this is the central theme of lacrimal function unit. Definition of dry eye is given by Dry Eye Workshop 2 in 2017 as dry eye is a multifactorial disease of ocular surface characterized by loss of homeostasis of tear film and accompanied by ocular symptoms in which tear film instability and hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play etiological roles. That means there occurs hyperosmolarity of tears, which results in inflammation of ocular surface and resultant damage, where etiological role of neurosensory abnormalities is definitely there. So pathophysiology, as we have seen, lacrimal function unit dysfunction will result into inflammation, unstable tear film, and dry eye. This is again classification in 2007 report of International Dry Eye Workshop. To simplify, we can classify it as aqueous deficient dry eye, maybe Sjogren's syndrome dry eye or non-Sjogren's syndrome dry eye, where there will be dryness of mouth accompanying with or without systemic diseases. Second one is evaporative dry eye. It can be either lid related, where there is meibomian gland dysfunction or problem of blinking, or it can be due to ocular surface like contact lenses, or it can be mixed dry eye. About the risk factors for dry eye, the most common risk factor is aging. With advancing age, there occurs changes in the lacrimal gland, acinar structure of other glands also, changes in the lid structure and blinking, reduced corneal sensations, and undiagnosed autoimmune diseases, which will result in dry eye due to aging. Dry eye is also common in females due to hormonal changes. And air pollution is again the very important factor. And to add, as Vaishali has mentioned, dry, hot weather, along with that, air conditioner use will also add to the dryness or dry eye. So those patients who are engaged in computer or mobiles or busy in microscope, there is more incidence of dry eye. It is common with systemic diseases like connective tissue disorders, Sjogren's syndrome, ocular cicatricial pemphigoid, Stevens-Johnson syndrome, etc. With menopause, there is more incidence of dry eye, firstly because of aging and second thing because of decreased levels of androgens. It is also more common with contact lens wearers. So this is the list of topical medications causing dry eye, which we routinely use, like anti-glaucoma, anti-allergic drugs, mydriatic cycloplegics, and benzalkonium chloride as preservative. All of us know that it is toxic and results into dry eye. These are the systemic medications causing dry eye, including hypertensive drugs up to antidepressants. Meibomian gland dysfunction is commonly associated with dry eye. In this disease, there occurs alteration in the quality and quantity of meibum which is secreted, resulting into unstable tear film and evaporative dry eye. It is commonly associated with acne rosacea, atopic dermatitis, etc. And this meibomian gland dysfunction is increased with aging. Diabetes is a very significant risk factor for dry eye. It has its effect on lacrimal gland in the form of autonomic neuropathy, microvasculopathy, sorbitol accumulation, and reduced trophic support. It also affects conjunctiva and cornea in the form of goblet cell loss, reduced corneal sensitivity, and reduced reflex secretion of tears. We at our institute have conducted a hospital-based cross-sectional study where 115 diabetics and 115 non-diabetics underwent tear film breakup time, Shermer's test, and Rose Bengal test. And the conclusion is that tear film secretion and stability of tear film are significantly reduced in diabetics as compared with non-diabetics. LASIK is again a very significant risk factor for dry eye, though the dry eye resultant dry eye lasts only for few weeks. Cornea gets its nerve supply by long ciliary nerve, which is the branch of ophthalmic division of trigeminal nerve. At 3 and 9 o'clock, the two major trunks enter cornea. In case of superiorly hinged flap for LASIK, there occurs damage to these nerve plexus nerve entries at 3 and 9 o'clock, and stromal nerve fibers are also damaged because of photoablation. The other factors are goblet cell loss because of high pressure because of suction ring and medication damage. So many other ocular diseases like meibomian gland disorder present as same symptoms as that of dry eye, like foreign body sensation, itching, irritation, etc. But in case of meibomian gland dysfunction, there is early morning pain, irritation, and crusting that improves as day progresses. Then the causative factors and prolonged visual efforts will add to the presence of dry eye. Now we'll see the symptoms of dry eye. They are irritation, redness, tearing, burning and stinging sensation, dryness and foreign body sensation, along with itching, photophobia, blurry vision, so many symptoms and contact lens intolerance, and triggered by wind, air travel, or low humidity, and prolonged visual efforts. In case of dry eye, we have to take detailed ocular history, including topical use of topical medications, contact lens wear, allergic conjunctivitis, and history of refractive surgeries. Slit lamp examination should include lid margins for presence of blepharitis or meibomian gland dysfunction. Cornea should be inspected for punctate erosions, filaments, mucus plaques, and tear film for height of tear meniscus, which is normally up to 1 millimeter. It will be less in case of dry eye, and other features of tear film like debris, mucus strands, and foam. These are the various tests for tear film function. For stability of tear film breakup time, for quantity of tear production, Shermer's test, and to know the status of ocular surface, fluorescence staining, rose bengal staining, and lissamine green staining. So these tests will be covered in detail by next speaker. So the take-home message is dry eye disease should be detected early so as to improve patient's comfort and to prevent or minimize further structural damage to ocular surface. It is recommended to evaluate various etiological factors like diabetes, old age, contact lens wear, LASIK for optimum management of dry eye. So these are my references. Thank you.
Thank you, Dr. Varsha, for giving such a detailed review of pathogenesis and risk factors. Since before we actually treat the dry eye, we have to remove the risk factor, modify them as much as possible. And that forms the mainstay of treatment before actually starting treatment with eye drops or drugs. So thank you, Varsha, for a nice presentation. There's one discussion that we had that during COVID-19 period, we are getting a lot of what we say as mask-induced dry eye. So that would from probably another risk factor, wearing mask all the time. It directs the exhaled air into the and causes dry eye. That's what they say. But there are a lot of studies that are coming in on that also. So thank you, Varsha. I pass on this mic to Dr. Architre for your next speaker.
Thank you, sir. The next speaker is Dr. Himanshu Matalia. He will talk on diagnostic in dry eye case. Dr. Himanshu completed his education from MP Shah Medical College, Jamnagar, and Cornell Fellowship at LV Prasad, Hyderabad, and later served as a consultant at LVPI. He also received training from Wilmer Eye Institute, Johns Hopkins University, USA. He has published in various national and international journals and is a reviewer for many international journals. Now, I request you to continue with your topic, sir. Himanshu, sir.
Thank you. And I would like to extend my warm welcome and thank you to all of you. And it's a pleasure to have a webinar after dinner and such a convenient time. And I'm so happy and thankful. I'm going to share my screen with you. So the topic given to me is diagnostics in dry eye. I'm not here to teach you anything, but there are some small pearls which I would like to share with you, and with every topic we'll keep talking about such kind of thing. So when we talk about dry eye diagnostic test, the gold standard are questionnaires, quality of vision, ocular surface staining, tear film breakup time, and Sherman's test. All these things have been there for a really long time. But if you look at it, do you think that they can actually give you root cause, or this is the effect of dry eye? The answer is this is effect. None of the tests actually tells you about the root cause. Why does it matter? Why should we talk about root cause where finally we are treating everything with lubricant? But the answer is that, do you think all the dry eyes are same? Do you think a dry eye with rheumatoid arthritis can be same as dry eye with meibomian gland dysfunction just because Sherman's values match? The answer is no. Of course, we all know that's not true. That different dry eyes cannot be same. So you need to know about the root cause. And whenever we talk about root cause, that's where the diagnostic test comes into picture to know about the root cause of the dry eye. Whenever we talk about any diagnostic test, there are certain questions which I would like to ask. One, does it help me in diagnosis? Does it help in deciding about the severity of disease? Does it help in treatment? Does it have good repeatability? Does it have good sensitivity and specificity? And finally, is it good value for money? Now, the simplest thing when patient come and when they are sitting outside in your waiting area, the question is, the most handy thing to document the subjective part of the dry eye. And it's very important, which helps you to decide about your treatment, whether patient is responding or not. Finally, remember, it's not what you feel, it's about what patient feels. That's more important. So when they come to you, if we do not take care of their subjective symptoms, they're not going to be happy. So the questionnaires are many of them. The commonest use in our practice are OSDI questionnaire, but you can use whatever suits you. The clinical diagnostic test, what we have been using for very, very long time, includes fluorescent staining, which not only stains the surface, but also helps us from breakup time. Rose-Wengal or Lisman green staining to know the surface viability, and the Sherman's test to know the turnover of tear film. The testing alone is not important. To document these kind of things is also important. And personally, I like to document them in a little different way, where the cornea I divide horizontally, whereas the conjunctiva I divide vertically, which helps me in not only the documentation, but it also helps me in the real life scenario where the staining pattern is different in different zone of the cornea, depending upon the etiology. Coming to the interpretation of tear film breakup time, apart from the breakup time per se, the tear film breakup pattern, which has been recently proposed by Asia Cornea Society, can also give you some etiological idea about the disease. Like if you have an area break, well, that can be related to aqueous deficient dry eye. The breaks which you are seeing in the second video, which is spot breaks, which is usually with less wettability, and so forth. So next time when you do a tear film breakup time, Apart from the time, also pay attention to the breakup patterns. Coming to the diagnostic instruments or tests. Now, there are so many of them in the market. Which one to buy? Well, again, we discussed previously that whenever we talk about the root cause of anything, we have to know about the pathogenesis of that. And pathogenesis of dry eye, these are the four major cornerstone of pathogenesis of dry eye: hyperosmolarity, apoptosis, inflammation, and TFM instability. Coming to the hyperosmolarity. The osmotic damage has been widely reported in literature. And now we do have instruments which can measure the osmolarity. These are called osmometry. And they are from Tier Lab, USA. What it measures is, it measures your osmolarity in the number. And what company has advised that if you have osmolarity which is more than 316 milliosmolar per liter, then it's dry eye, and less than 290 is normal. It's fine. Now, coming to the correlation or clinical implication of this thing, there's huge amount of test-retest variability in case of osmolarity, and especially cases which are abnormal, which are dry eye, they have very high variability. The normal cases, in fact, has less variability. Also, there's a huge crossover, or rather overlap, between dry eye and normal cases. So it's quite possible you may get some abnormal values and you realize that the case is actually normal. Also, there are cases where it has been reported in literature that whether it's a mild case or moderate case, the osmolarity can be same. Etiology-wise, whether it's a Sjogren's or non-Sjogren's or a normal case, the osmolarity can be same. So looking at this thing, if we answer all those questions which we raised earlier, does it help in diagnosis? Does it help in severities? If you actually go through the list, you realize that this is not an instrument which is worth buying. Spending so much huge amount of money, I don't want to take an instrument which does not help me in any of these things. Coming to the next part, which is inflammation. When we talk about the inflammation, we know now that the dry eye has been documented to be an inflammatory disease, which earlier we did not know. And interestingly, it's a white inflammation. Though the eyes may look relatively white, but there can be significant amount of inflammatory mediators in the tear film, including the activated T cell and IL-17, and more so MMP9, which has been widely studied by Dr. Flugfelder's group. Now, fortunately, we have a test where we can check for the MMP9 level. This test is very simple, like a pregnancy test. You take the sample from the lower palpebral conjunctiva, and within a few minutes, you get an idea whether MMP9 level is significantly high, which is more than 40 nanogram per ml, or it's less than that. Well, how does it help? Well, if the MMP9 levels are significantly high, we know that in treatment, we have to use anti-inflammatory molecules. And if the MMP9 level is less, we may be able to just get away without using such thing, and we may be able to just use lubricants. Is it very significantly important? Well, yes, when there are cases which have significant chance of inflammation, like bone marrow transplant, autoimmune disorders like rheumatoid arthritis, Sjogren's, thyroid dysfunction, such kind of cases, you must start anti-inflammatory in the beginning only. You do not have to wait for damage to occur. So if we know that significant amount of inflammation is there on surface, well, we can use such kind of molecules. So if we go through the same list, is it worth keeping in our armamentarium? Well, looking at the cost, which is probably a couple of thousand rupees or 1,200 around that, I don't mind keeping in my kitty to check especially these cases which are high-risk cases. Coming to the next part, which is TFM instability. Now, TFM instability is typically due to the meibomian gland dysfunction, and we know that blepharitis, MGD, all such kind of thing can lead to such meibomian gland dysfunction. And that's where the meibography comes into picture. Meibography is nothing but the imaging of meibomian glands The left side picture, you can see the normal meibomian glands, whereas the right side picture shows significant amount of loss of meibomian glands. Why is it important? Well, we know that traditional teaching says that if we have significant MGD or meibomian gland dysfunction, the treatment is warm compressive lid massage. But if we do meibography using whatever meibographers you have, if the meibomian glands are present, this is going to work. But if meibomian glands are absent, like this case, whatever you do, even if you jump over the lid, nothing is going to come out. So it's not going to help. So meibographers are many in the market. Even if you do not have meibographer, any infrared device which is there in your clinic may actually help you to image the meibomian gland. I had been using my autorefractometer for many ages before even the meibography was available. The only thing is I had to click picture with my phone, but this way I could at least have the imaging of my meibomian glands. So this way, even if you do not have any meibographer, you still can do meibomian gland imaging. So meibography, is it worth having in your armamentarium? Of course, yes. Because if we do not have the idea about the status of meibomian gland, treatment would be totally useless. There are certain diagnostic devices which are comprehensive dry eye diagnostic devices like keratograph 5M or ocular surface analyzer, which can do many things from like topography, which is done by keratograph, to meibography, non-invasive tear film breakup time, lipid layer analysis, lower tier meniscus, pupillometer, white to white, and many things it can do. It can actually, apart from doing all these things, it can actually take a decent quality diffuse picture also, and it has wonderful Ratin filter, and fluorescent images are wonderful, and it can give you very nice treatment output also, or the advice. So having such kind of instrument in your kitty can certainly help if you're serious about dry eye clinic or dry eye treatment. There are certain other newer diagnostic devices like LipiView, LipiScan, which came. Earlier, the LipiView did not have the imaging of meibomian glands, but now the newer model LipiView 2 has both where it can image the meibomian gland, it can also image the lipid layer, and looking at all those things, well, if you already have it with you, I would certainly use them. So if you want to buy a meibography and if you are getting a LipiView along with that, absolutely no problem. But you do not need to buy such instrument if you have any form of meibography available with you. Quality of vision assessment is another part of unstable tear film. The quality of vision can be assessed using abrometer. An abrometer, as you can see from distorted image here, this was related to dry eye, and drop of lubricants when patient was started with, patient had significant amount of improvement. So you certainly can detect the quality of vision using your abrometer. But if you look at whether it's worth buying as an instrument standalone, I don't think I would waste my money for a dry eye treatment or dry eye diagnostic to buy abrometer. But if you already have it, you might as well use it. Lastly, detecting Demodex follicularum, which are these mite cousins which can live on in the eyelashes as well as the meibomian gland, can be easily picked up by light microscopy. So another diagnostic device which you can use is your normal compound microscope, and detecting these bugs is pretty easy. Pick up a few eyelashes from upper lid and lower lid and see them under the microscope, and you can actually see them moving. The treatment includes tea tree oil, and which can kill such kind of mites within a short period of time. Finally, the dry eye kit, which is something very simple, which any individual person who is interested in being a visiting dry eye consultant can keep, which can have questionnaires, different strips inside MMP kit. You can keep punctum plugs, punctum probes, meibomian gland expressor, and appellation forceps along with the slides. You can put them in the bag, and on the go, you are a visiting dry eye consultant. Finally, to conclude that there are certain mandatory tests like fluorescent staining and T-beauty, staining of the ocular surface using lecithin green or rose bengal, Shermer's test, and a meibographer. Rest of the tests are not mandatory. If you have it, you certainly can utilize them. To summarize, not all the dry eye are same. Treat the root cause of a dry eye, and to know the root cause, you need to appropriately investigate dry eye. Questionnaires, corneal staining, and Shermer test are very important, along with meibography, which can help you to detect meibomian gland dysfunction. Thank you very much.
Thank you to Himanshu for exhaustive coverage on the diagnosis of dry eye disease. Such a vast topic to be covered so efficiently is very, very difficult. Let me ask you one question. What would you advise to a general ophthalmologist who doesn't have any dry eye specialty equipment, which is a single test that he should do to at least suspect, if not diagnose, a dry eye?
So that's what the last part of that thing was, that the dry eye kit which we can make, everything, every general ophthalmologist will have. Whether you talk about questionnaire, which all the companies will give you free of cost, or you can download also. All the strips which you have, Shermer strip, you would have fluorescent strip, you have rose bengal, you have, and of course you can have a forceps which you can use to pluck the eyelashes. You get very easily, very cheaply meibomian gland expressor, these kind of forceps. And of course, you can get access to an autorefractometer to do a meibography. So you can do a comprehensive dry workup, whether you are a general ophthalmologist sitting in a remote corner of a country or in somebody who's sitting in a metro. You can give them run for their money if you have even these basic things with you. But if I have to choose one test, which is not right for me to choose only one, but if I just have to choose one test, and that would be tear film breakup time. Tear film breakup time is highly underutilized and something which most of the patients, if you look at, they would be evaporative dry eye patient. And if you have to do one test, it would be tear film breakup time. Having said that, rest of the tests are extremely easy, and let's do a complete workup.
Yeah. Another question, this tear film breakup time, really a difference between the one that you would do with fluorescein and the one that you do non-invasive? Is there a difference in values or cutoff points?
Yeah, so there is difference in value, but interesting part is that both of them have limitation of repeatability. Both of them can have some variability in repeatability. But the simple and important part is, if you have one, stick to that. So if you have examined your patient on one particular way, like say fluorescent tear film breakup time, well, follow it up with the same thing, and it's still fine. So what matters is that how you are able to follow up your patient consistently in the same method, and that's good enough.
Thank you, Dr. Himanshu, for a nice talk. Now over to Dr. Arun, the next speaker.
Thank you, sir. Now I request Dr. Hemant Anaspure to speak about pediatric dry eye. Dr. Hemant, after completion of MS from KEM Mumbai, he presently working as the director, pediatric ophthalmology and strabismologist at Sri Sarveshwar Netralaya, Aurangabad, and also a joint director for Arambh ROP screening project. I request Hemant to continue with your speech. Dr. Hemant. Hello.
Hello, can you listen to me?
Yes, sir, we can.
Hello.
Hello.
Please share your screen, Dr. Hemant.
Okay, so can you see the screen now? Hello.
Yes, we can see.
Okay. So first of all, I would like to thank Aurangabad Ophthalmology Association and Maharashtra Ophthalmological Society for giving me this opportunity and talking in front of all the experts in this field. Now, I am sticking to the topic of the pediatric dry eye. Only thing I will cover is particularly related to the, because the rest all are covered by the other eminent speakers. Now, dry eye, as we have seen, is a multifactorial disease of the tears and ocular surface, and it is more common as the age advances. So it is more commonly seen in the elderly patients. But now, with the increasing popularity of the computers and the video games or the smartphones in the younger generations, growing number of children are now exhibiting with the symptoms like frequent blinking or sensitivity to the light or other dry symptoms. Now, with the COVID era, now these online classes are becoming very popular in the urban as well as rural population, which has increased our problem many folds. Coming to the prevalence in the adult age group is from 5 to 36 years. As the age advances, the prevalence of the dry eye become more and more common. In pediatric age group, there are fewer studies, but it is approximately between 6 to 10% of the child can have a dry eye disease. Given this lower prevalence of the dry eye disease in the children, the diagnosis of the dry eye is often overlooked into the children. But with the recent pandemic situation, the use of the smartphone has increased drastically in both urban as well as rural population. Hence, it will be interesting to look into the recent data now. Definitely, the prevalence is likely to increase. Coming to the tear film chemistry, the slight difference between the pediatric age group and adult is that the child's lacrimal system produces more tears compared to the adult's lacrimal system, and the non-aqueous portion of the child's tear film contains lesser lipids, also mucus compared to the adult's tear film. Classification of the tears, we classically classify dry eyes into either it is a tear deficient dry eyes or evaporative dry eye. In a pediatric age group, it is more common of a evaporative dry eye disease, which is common, while the tear deficiency is more common in the adult age group. Causes, as already enumerated by the madam, but same causes are there in the pediatric age group also. Systemic causes like Stevens-Johnson, Sjogren's syndrome, juvenile rheumatoid arthritis, any child undergoing radiation or chemotherapy for the cancer, or those who are suffering from the diabetes. Increased visual task activity or screen time, like a computer and mobile, is a major factor nowadays of dry eyes in the children. Other causes like blepharitis, ocular rosacea, or meibomian gland dysfunction, ocular allergies are very common in children, vitamin A deficiency, contact lens failure, the other causes, which can cause dry eye in children also. Now, the major concern, as I said, is the mobile abuse. The younger and younger children are nowadays, you see, in coming to the OPD and opening the YouTube themselves and keep watching in front of you also. So the mobile abuse is a major factor. It is not only causing the dry eye disease, but it is leading to the sleep disorders, headache, myopic progression, and the aggressive behavior. Symptomatologically, again, difficult to make the diagnosis of dry eye in children because they may not be as expressive as adults as far as symptoms are concerned, and they may not be able to tell it very accurately. But most of the parents will tell you about the excessive blinking or rubbing of the eyes in the children while they are studying or while watching the television. Now, older children can tell you about this variety of symptoms which are common in the adults as well. Now, the diagnosis part, like difficult again in the pediatric age group is one thing is their symptoms may not be very correctly they will be able to express, as well as all the objective tests, they may not be very cooperative for doing this objective testing. So, history plays a very important role when we think of diagnosis of the dry eye in these children. A lot of information can be gathered from the mother, particularly about their systemic illness, their allergies, their contact lens wear, use of their mobile screens, television, laptop, their reading habits, their outdoor activities, whether they are rubbing their eyes or blinking, use of spectacle. All this history will probably lead you to take you to the diagnosis. Now, symptom question is like OSDI, which is commonly used in adults, can be used in the pediatric age group also, even though we may not have the data for that, but definitely that can be used if you want to. A lot of the tests, sir has said, the tear wake-up time and the Shermer's test, definitely we can do if the child are cooperative. I would just like to review this article about the smartphone use because that is something which is more concerned nowadays. about the dry eye condition, because that is one of the major factors that might be lead to the increased prevalence of smartphone use. In this study, the author has studied around 950 children in relation to the smartphone use, depending on the region and the age. Some results were very interesting. One thing is the rate of the smartphone use. Almost 96 to 98% of the people in the dry eye children, they were using the smartphone. So almost all were found to have a smartphone user. And if you look at the time of the hours, it was almost more than 3 hours of a smartphone user in this. They studied about the protective factors also. And if you look at this outdoor activity, the control group has outdoor activities more than 2.5 hours of the outdoor activity, as compared to the dry eye disease group, which was less than 4.5. So the prevalence of the dry eye they have seen is more in the urban compared to the rural area. So some of the results which they published is the rate of smartphone use was drastically higher in the dry eye disease group compared to the control group. Mean duration of the smartphone use was only risk factor for pediatric dry eye, while the mean duration of computer usage, TV watching, or learning was not significantly different. Increased outdoor activity reduced the rate of the pediatric dry eye. Now, the great portion of the students in the dry eye disease, they were urban compared to the rural patients. Now, dry eye disease was prevalent in females, in males, as in adults also. Now, probably along with the hormonal changes, probably the lesser of the outdoor activities may be the risk of more prevalence in the female. It was higher in the older grades because probably they were using more mobile compared to the younger grades. One thing they have said that after cessation of smartphone use for 4 weeks completely, both symptoms, subjective as well as objective signs, they improve. So definitely we have to look in that. Coming to the last portion, that is the treatment part. Again, there are a lot of things which are available for the treatment. Two things which I would like to emphasize is first thing is a lifestyle change. It is the simplest and most effective way to relieve the symptoms of the dry eye. Child are more likely to listen to you if we talk to the child directly, and so that we should spare at least 2 minutes of our consultation. Along with talking to the parents, we should talk directly to the child. And in all the patients who come to me, I actually tell them these things, that they should wear spectacles all the time, avoid use of the mobile screen. If possible, use a bigger screen for the study. Keep screen time to the bare minimum time which is required. No screen in the evening or at night. Only during the daytime they can use the screen. Watch for the brightness of the screen. Compulsory outdoor activities of at least 2.5 hours every day. Diet rich in vitamin A, adequate sleep. These are something which will prevent the child from getting the dry eye disease. Another thing which is important in the pediatric age group, particularly the lid hygiene. They will have a poor lid hygiene. They will not wash their hands. They will keep rubbing their eyes. So you get a lot of lid related problems. Warm compresses, topical antibiotics, they will help us to treat the dry eye disease, particularly in the pediatric age group. In conclusion, dry eye disease in children is, if detected early, and should be treated with appropriate medical and environmental intervention and education. Thank you, and very much.
Thank you, Hemant, for an excellent presentation. You covered nearly everything that our kids do. I have a couple of questions for you. One is that how many kids do you encounter dry eye secondary to vitamin A deficiency?
Vitamin A deficiency as such is a lesser common now, sir. Particularly, I feel in the private practice nowadays, maybe in a government setup, might be seeing more patients. So directly conjunctival xerosis and corneal, these severe symptoms are not there. Okay, but junk foods and all those things which are not very vitamin, we can discourage them from having that.
Okay. And do you see MGD, meibomian gland disease in pediatric age group? Do you encounter any patients with meibomian gland dysfunction?
Again, sir, more common with the allergy and this thing. Meibomian dysfunction is less common.
Okay. And now we cannot control their screen time. So, do you advise any tear supplements for children who are having online classes or cannot cut down screen time?
Yes, sir. If they come with the symptoms, definitely we can tell them to use them along with other lifestyle modifications, which are more important than using the tear substitute. Because tear substitute can be used maybe for a couple of months, but online classes are going to be there for some longer time now. So probably better to tell them to make a lifestyle changes compared to the using just the tear substitute. But yes, for the temporary relief, they can use it.
Thank you, Hemant. Over to Dr. Arun for next speaker.
Thank you, sir. Now, Dr. M. Nishan will talk on treatment of dry eyes. Dr. Nishan completed his MS from Arvind Eye Institute, Madurai, and fellowship in corneal and refractive surgery from Shankar Netralaya, Chennai. Presently, working as a clinical director of MNI Hospital, Chennai, with well-equipped eye bank, and he is also a very well-known sports person also. I request Dr. Nishan to continue with the session of treatment of dry eyes.
Thank you so much, Dr. Arun, sir. Yes, I'll just share my screen. Yeah. I would like to thank Aurangabad Maharashtra Ophthalmic Society and Dr. Vaishali for giving me this opportunity. So I'm going to talk about the treatment of dry eyes. Yes, we all know that when we have always an option, there are actually too many options when it comes to dry eye disease and treating them. So what is the ideal tear substitute? What are the steps we actually think about before prescribing a tear substitute for a particular patient? Is it just because of their symptoms? Is it just because of their signs, what we see? Or is it just because of their history and where they are working from? So it should also, we all know that the ideal tear substitute should work like a normal tears. It should not alter the clarity, because that is most important for people who actually complain of blurry sensation when they use the gel in the morning time. It should lower the surface tension of the tear film, should not react with tear proteins, and should not alter the lipid layer. So how can it be done? Prevention of exacerbation factors such as environmental changes and surgery from lip deformities. Tear supplements, yes, I'm going to talk in detail about it. And there are also other modes and modalities such as tear retention by different means and surgical as well. And there are also secretogonous things and the biological substitutes. So we also have anti-inflammatory therapy, and there are other machines that actually help in treating dry eye as well. So what is an ideal tear substitute? It should be comfortable to use without any epithelial toxicity. The pH should be in a normal range between 7 to 7.5. The osmolarity, which was covered by Dr. Himanshu, it should be around 300. It should be allowing a clear vision, and it should not leave any residue. The most important aspect in medical management is the patient's compliance. Irrespective of what we give, how many times we give, we should always make sure that the patient compliance is the most important. So the benefits of a tear substitute. Yes, we know that it provides adequate relief, increases the humidity of the ocular surface and improve lubrication, the smooth ocular surface leading to improved vision, and intra and post-operative use has shown to help in restoring ocular surface after refractive and even cataract surgeries as well. So how is the treatment plan? It is definitely based on the levels, the symptoms, the signs which was there due to the conjunctival and corneal staining patterns, and utter all the other treatment options based on the severity level. Yes, we have the DUSE classification where they have classified in 4 levels. The level 1 mainly consists of the education and environmental modification, which is also actually an important part because most people who come to me are from the IT company. So they have the AC straight on their face, and just a change in the direction of their table to be away from the air condition makes a lot of difference. So try to find out the patient where they are working, how they are working, and how many hours they are working to start with the environmental changes as well. And when we go to the level 2, yes, we have the non-preserved artificial tear substitutes. We have the anti-inflammatory agents, the tetracycline punctal plugs. The 3rd level goes to the autologous serum, contact lenses, and permanent punctal occlusions. And the final 4th level of severity in the dry eye, we have to undergo other amniotic membrane transplant and systemic anti-inflammatory agents. So To classify the lubricants, we have the polymers, the hydrophilic, the polysaccharide polymers, the hypromellose, and the buffers, electrolytes, and the preservatives. So first, I just want to talk about the cellulose, which actually has a property of viscoelastic polysaccharide. It is co-formulated with electrol and as hypotonic. The advantage is has had good retention time, mixes well with ophthalmic products. Viscosity is not influenced by blinking. But the only disadvantage is it is working only for aqueous deficiency, and hypromellose can cause crusting as well. The carbomers, which are actually synthetic polymers, have high viscosity when the eye is static. It is thin during a blink. It is very good retention time, but it actually tends to blur the vision and sometimes uncomfortable for the patients as well. The polyvinyl alcohol is a synthetic polymer which has low viscosity, put an optimal wetting concentration of 1.4%, but it is very beneficial in lipid, aqueous, and mucin layer deficiencies, which is water soluble and does not cause any blurring of vision. The only disadvantage is a short retention time and does not mix well with other ophthalmic solutions. Now, the sodium hyaluronate, which is actually becoming more as the first line of treatment compared to CMC, which is a mucopolysaccharide, which is a viscous formulation with a good retention time. But as I think we are, the clinical experience as lots of trials are coming, showing that the use of sodium hyaluronate is very good and with less amount of times which is put for the patients. We have the povidone, which is a synthetic polymer co-formulated by electrolytes, superior wetting ability when co-formulated with polyvinyl alcohol, and it's a very beneficial mucin layer deficiencies. And finally, acetylcysteines break down the mucin molecule, useful in complications with very dense mucus and very severe dry eye, and not commercially available as topical drops. And finally, you have the lipids, which are the thick organic substances formulated for drops and mainly the ointments, high viscosity, and therefore the retention time is much higher. It rebuilds the lipid layer, useful for adjuvant or tears when it's used in the night. But yes, morning time causes blurry vision and little less experiences. So what is the recommendation to use? We categorize as mild, moderate, and severe diseases. Based on that and the DUCE classification, you also can segregate what kind of medications and what kind of treatment should be given for each kind of diseases. And the anti-inflammatory therapy, yes, you have the cyclosporin, the corticosteroids, and the tetracycline, where the cyclosporin is actually 0.05 to 0.1%, which is used daily twice. It is available as cyclomune, cyclosporin, restasis. The dial is used for 12 hours apart. The only thing which patients complain is of the stinging sensation. So sometimes I ask them to use a lubricant drop and then later on use a cyclosporin. The corticosteroid, which is a potent anti-inflammatory, the mechanism of action, we all know that it inhibits the inflammatory cytokines and decreases the matrix metalloproteinase and the PGs, decreases the expression of adhesive molecules, enhances lymphocytes apoptosis, and it's actually very suitable for an acute dry eye exacerbation. But long-term use must be definitely restricted because patients, once they feel very comfortable, they start using it over the counter even without you prescribing it properly. The tetracyclines, we know that it recently have shown that numerous anti-inflammatory properties with regards to ocular surface. They decrease the interleukin-1 and the matrix metalloproteinases. Dosage of 40 to 50 milligram a day in divided doses. And if patients are not able to use only the medications and still you have an epithelial irregularity or persistent epithelial defects, that's where the bondage contact lens comes into place, which has a high water content. It can be left in the eye and it not be removed. It is intractable filament keratitis and non-healing epithelial defect is the main indications. The only disadvantage is you need a close follow-up because there's always a risk of infection and may also worsen existing dry eye, acting as a sponge. When we come over to the surgical treatment, the first thing will be the punctal occlusion, where it can be a temporary or a permanent one. We have a lot of collagen implants. We can use a chromic catgut for occlusion, silicone plugs and gelatin rods and cyanoacrylate adhesives as well. The permanent comes with a cautery, laser and electrodissection. So we know that the collagen plugs, they are different sizes. You have the silicone plugs. I have a picture to show you. Yeah, the ODC punctal plugs, the Herrick lacrimal plugs and the smart plugs. When we go to the permanent occlusion, this is a cautery which I use usually. So I start by seeing the tears, the non-invasive tear bud, the amount of fluorescent which is actually being removed after a minute or two, because sometimes with nasal simulation, we have to see whether the tear reflex is there or not. Because if we permanently occlude as the first line of treatment, the next day sometimes patient come by saying that I was dry, but now my eyes are watering. So always make sure to see for the reflex tearing before you decide on a permanent occlusion, and try to reduce the steroids, because these steroids sometimes open up the occlusion as well. So other surgical modalities are tarsographies, correct the lids, that is by atropion or entropion, botulinum toxin injections, amniotic membrane transplant, mucous membrane grafting for lid keratinization, and other ocular surface reconstructive procedures. The parotid and submandibular gland duct replacement for inferior fornix, transplantation of minor salivary gland into the inferior fornix, which I'm actually not well aware of. The recent advances, you have the stimulation of tear secretion, hormonal supplementation, fatty liver derivatives, topical vitamin A, antiviral, autologous serum is actually something which I use for severe dry eye, AMT, stem cell transplantation, and gene therapy. So tear stimulants, we have the bromohexidine, the olopilocarpine, and P2Y2 receptor antagonist. The hormonal replacement, it has been shown that there is a decreased androgen in dry eye patient. So there is a phase 3 trial in the US. And we ask them, patients who actually have non-veg, I think this is one question before we prescribe an omega-3. I always ask, because sometimes the patient go back and come and saying that there is some amount of fish oil contents which we are not supposed to have. So before prescribing oral supplements, please make sure that the patient are comfortable in having the medicines. Topical vitamin A, antiviral agents, autologous serum preparation, which I'm going to show you now, and about the smart plugs, which I told you. So autologous serum, it actually contains growth factor, the fibronectin, epidermal growth factor, TGF-B, vitamin A, MMP inhibitors, and immunoglobulins. 20 to 100% concentration is used with the duration of 6 to 8 weeks. So the role is for severe dry eye where there is severe ocular inflammation, and limitation is requires special preparation and risk of infection, and it's very short life. So using the 18 gauge needle, approximately 40 ml blood is collected into a 8.5 cc blood tubes. It's kept aside to clot for about 2 hours in room temperature. Then the blood is centrifuged at the speed of 5,600 RPM for 10 minutes. The serum is filtered to remove the fibrin strands. And then from that, you take 8.5 cc tube of blood, yields approximately 4 cc of serum, which you can bottle it in a sterile and give it to the patient. So yes, sometimes lubricant also makes the changes in the Scheimpflug images. You can see that the anterior axial curvature and the elevation in the front completely changes when you actually put a lubricant. So even for refractive surgeries, make sure that preoperatively also the tears is a very important structure before we take up for surgery. And also one more thing is treat the underlying cause. It's the meibomian gland dysfunction, by which can be treated by hot fermentation, lid massages, scrubs, tetracyclines, tassoraphy, hormonal therapy, or systemic immunotherapy. And supportive therapy, you have the moist chamber glasses, the eye shield, the reduction in room temperature. Sometimes a room humidifier also helps in treating these severe dry eye patients. Newer modalities, I'm very happy that Dr. Himanshu sir has actually covered it. So that is what I was actually going to talk about, the LipiFlow, which is really good in terms of treatment. And always combine it with some artificial tears for these patients. And sometimes one sitting might not be enough. They might require 2 or 3 sittings. And you have the IRPL, the intense regular pulse light therapy, also for meibomian gland diseases, and the EI devices, which is also there. So there is a lot of devices which is coming to the market for treating severe dry eye as well. In conclusion, I want to say that it is a common problem for all ophthalmologists and patients, and there is no single treatment option works for all patients. One thing which I want to say to all is make sure that you listen to when the patient is having a dry eye, either in the morning or in the evening, or is it due to only the humidity, or is it due to some allergy? Because there can be a lot of underlying treatment where we have to treat the allergy and the dry eye gets better. Identification of the underlying cause aids in successful treatment, and long-term treatment needed is always there mostly for these patients. I thank the Maharashtra Ophthalmic Society and Aurangabad Society for this opportunity. Thank you so much.
Thank you, Dr. Nishant, for such a exhaustive coverage of treatment modalities in dry eye. So there are so many treatments that means that none is ideal, obviously. There is nothing that I think we had a lot of questions about which eye drop to use and which kinds of eye drops are available and the different kinds of tear substitutes that we're getting. But you have made it very clear and very nicely put. So there is nothing that I should be adding here.
So, thank you, sir.
Vaishali, do we take the questions now for everybody, or we wait till?
So we are very fortunate that in spite of such hectic schedule, our Director Medical Education and Research, Dr. Padma Shri, Dr. Lani sir has joined us, and we are fortunate that today he just finished the task force meeting with the Chief Minister. In spite of his hectic COVID schedule, he has agreed, sir. I am truly honored that you have agreed to give a lecture on the dry cataract, how to manage. So I think we should go on with Lani sir's lecture, then we can discuss the questions. Sir, a warm welcome to you, sir, and I'm truly honored that you have accepted my request.
Vaishali, thank you very much. Parikshit, thank you very much. Swapnil, Ragini, thank you very much.
Thank you, sir.
Thank you very much. All MOS, thank you very much. I'm really sorry because the same time there was an emergency meeting in the task force. And the Dr. Matalia sir, Dr. Nishant, and I think I'm talking in the galaxy of the dry eye people. And so I think it is very difficult to speak in front of all these stalwarts in the dry eye. But Vaishali told me, "Ki, sir, you will have to speak something." So I will talk something here. But thank you, Matalia sir, and thank you everybody for coming and giving your inputs here. Basically, see I am very much thankful to the Aurangabad Ophthalmic Society and this all this mass giving me opportunity to speak on the dry eye. So I am not having any financial interest. But see now, the thing is this particular gentleman presented with the nuclear cataract and diminution of vision. Our mind starts planning cataract surgery and IOL. And in this, you can say, precluded mind, we don't examine further to miss the important finding. So here you will see and see the mebominitis here, and this, and see the now see what happens. Now it creates a frequently visiting patient, operated, and these are in the OPD, complaints of the pain and watering. Now why? Despite of the 6 region adds or the stress to us, and one unhappy patient running from clinic to other war city, and what happens? The doctor is stressed. So now, see, if you come to the an ophthalmologist, we have defined almost every disease we come across from the cataract as a lenticular opacity to glaucoma as a chronic progressive optic neuropathy. But we are still trying to define dry eye and yet not use the satisfactory definition. See, there are in 95 there was a different definition, in 17 there was different definition, and various definitions of dry eye with addition in each dry eye as inflammation, the neurosensory abnormalities are added just now in 17. So now once you see the and after this, the dry eye is really common, or only we are saying it, that it is study on ocular surface health of the cataract patient. It was found that nearly 63% of the patient have one or other type of dry eye in the age of cataract surgery. These are multiple factors which aggravate this dryness for surgical time, incision size, and the post-operative drops also. If you see this preoperatively, the misdiagnosis, intraoperative, increased surgical time, incision size, lens hardness, and that causes the inflammation, reduction in the goblet cell. Post-operative eye drop preservatives, that gives rise the problems. And C, with these, there are straightforward diagnosis of the inflammatory keratitis or severe dry eye, which we don't miss. But See what happens in that. You will see we should not miss quite looking eyes. Also, especially when we planning any surgical intervention in that, as we never know what are they, and so I think whenever we are examining preoperatively, so here these few important investigations should be done for every patient. You see the lead margin, we must see the orifices, staining, this T-butt and mammography. I think this is very very important whenever we are going for the cataract. I want to add on the case here, the 45 years old gentleman who presented with the small nuclear nebular corneal scar. You can see that scar and the cataract. Post surgery, he was fine and he left for his native places. The patients are coming from the rural area in Mumbai. 2 weeks post operatively, he presented with the surprisingly picture of this. You can see this was the picture after 2 weeks. There was no history of the trauma and the difficulty to correlate with the uneven pulled surgery. After stoppage of the steroid and starting of the lubricant, it resulted with the larger opacity which was less before. Now, what went wrong? Is missing the for the ghost cells. You can see the ghost cells and not checking corneal sensation preoperatively went wrong. Missed the diagnosis of the old herpes infection, which got reactivated with the course of post-operative drug that what we have used is the steroid. Now see the ocular surface very sturdy, but it's like a touch me not plant. Lazaru, that plant. There are multiple insult occurs. Surface go through the reacts. This is reacts with a particular fashion. See the systemic causes. You can see the autoimmune disease, SLE, rheumatoid arthritis, Sjogren's syndrome. So all these are they need combined management with the rheumatologist and ophthalmologist. It's very very important whenever you are doing this. Now the you can see the surgical factors from the incision to the surgical time matters as it increases inflammation of the surface, hence the dryness. The you can see these are the factors. You can see change in the temperature, disruption of the corneal sensation, nerves, meibomian gland dysfunction, disrupted lipid layer of the tear film, disease, decrease in goblet cell, change in the corneal sensitivity, alteration in the immune mediators, alteration of the ocular surface anatomy, and increase in the ocular surface inflammation. So these are the multiple factors like eyelid, neurotropically, previous surgery can make the dryness, and the preoperatively you can see this the lead disease, MGD, aqueous deficiency, neurotropic eye, pre-medicated glaucoma, preoperative. Here the you can see the this vernal conjunctivitis, then the ocular cicatricial pemphigoid, Steven Johnson syndrome. Post-operatively, ample amount of drugs causes harm to eye than the benefit. So many harms are there to the eye, and so whenever you are thinking this refractive surgery, CL wear topical people, low this lacrimal flow. But what is important is tear hyperosmolality. It plays a role. And what is the treatment? The treatment is multi-layer approach. It means the approach you can see go from the CMC, SPMC, sodium hyaluronate, the polyethyl glycol. So that is what you'll have to go with the ladder approach in these cases. Now, in the VKC, this does need a special mention as we do get many patients with VKC and developed glaucoma and cataract. So, because we are putting cataract, this steroid, and so the cataracts are coming. Since it is a child and adolescent, we should not over zealous to operate. So, I think that is very important, and we must refer the patient to the pediatric cataract surgeon. Non-inflammatory surface should be established before planning any surgical intervention, and surgery should be with a clear corneal incision. It's very very important. So this is the should be performed only in non-inflamed eye after active VKC is under control. Topical immunomodulator, or you can use the systemic immunomodulator. What is the duration? That duration may be secondary glaucoma or the LACD should be addressed. The second is what is the take-home message in this? The conclusions, the preoperative dry eye workup, ocular surface disorders, the cataract need holistic management approach. Cataract surgery should be customized for every patient depending upon the extent of the disease. Prior counseling about the aggravation of the primary disease and importance of the follow-up. Adequate use of immunomodulators. That is what is the conclusion. Thank you very much. Thank you, MOS. Thank you very much.
Thank you, Lani sir, for an excellent coverage on cataract. And whenever we see a cataract patient, everything else goes out of the mind. But here, it is to be distinctly remembered that eye workup should be done in patients of having a cataract, and you are considering surgery in that. So thank you, Lani sir. There is another thing, yeah. I was proposing that our Lani sir is contesting for the post of vice president in AIOS. So I implore first everybody to support him and encourage our colleagues and friends also from out of the state to vote for him. He's from our area, but he has been sort of a pillar of support for all ophthalmologists in our area. So we wish him all the best, and let's make him succeed in this endeavor.
And I just
100%, sir.
Thank you, everybody.
100%. And
Sir,
I think
and
we would also request
congratulations.
Dr. Nishan and Dr. Matalia also to spread in the good word.
Yes, sir. Definitely.
So I just take this opportunity to congratulate sir again for another Lifetime Achievement Award. I remember the last time we had taken a glaucoma CME, that time also we were so fortunate enough that sir had received an award, and today also I take great pride and happiness in congratulating sir. And sir, thank you really, and I just appreciate your that you have given time in spite in this COVID times, and your zest for academics remains motivation for us. Thank you so much, sir.
The dry eye is the topic of now close to my heart because Sumit is the student of Matalia, and whatever he has prepared, it was prepared by Sumit. So whatever I was reading, he is monitoring the cataract surgery in JJ. So I think Matalia, you have made Sumit very perfect doctor. Thank you.
Thank you, sir. Thank you for sparing the time for MOS.
Thank you so much, sir.
Thank you. Thank you, sir.
Thank you, sir.
May I leave?
Can we?
Sure, sir.
Yes, sir.
Sure, sir.
Yes, sure,
Thank you,
sir.
sir. Thank you, sir.
Ma'am, and can you also now take in the questions for the
Yes, sir.
speakers?
Yeah.
Yes, sir. Nargekar, sir. Yes.
Yes. So anybody has any questions for speakers, they can unmute and speak, or even send a question through chat if they want.
I have one question. Regarding if you were to take up evaluate a child for dry eye, then how do we compare the parameters, like the same parameters which we take for the adults readings, for the T-BUT, for the Shermer's test, or do we have special parameters for children?
Dr. Hemant, would you like to answer that?
I tried twice before this.
I think someone else's some video.
Yes, some talk is going on. I think since there's some hacking.
I was after that during my journey.
Okay. Hemant doesn't seem to be there.
I am here. I am here.
Yeah.
Yeah. But I think the parameters are same, madam. But I think sir will be better able to answer the material, sir. But there is no
Dr.
difference I
Himanshu,
could
can you
find.
please
Yeah.
write us?
So, like Hemant said, that I really don't think I would go by one particular test or anything. It's the entire thing. Now, in a child, if I have aqueous deficient dry eye, I would be looking at significant amount of other comorbidities and lot of other things which I would be looking at the child. if I have something else, and if I am looking for the aqueous deficient dry eye, then I would know that there are a lot of other syndromic things available. Having said that, when you talk about the evaporative dry eye in children, one thing I just wanted to add, when we talk about MGD, MGD includes two parts. One is the meibomian gland, and the second is the blepharitis part, or the anterior blepharitis, which is extremely common in young children. Many times you get children scratching their eyes. And one more sin which we always commit in entire ophthalmology is putting everything together as eye rubbing. Now, eye rubbing, there are two ways of eye rubbing. One, when you have an allergic eye disease, you rub the upper tarsal conjunctiva with the cornea, and you rub the eye like that. Whereas the second part of the eye rubbing is scratching of the lid margin, or somebody scratches the lid margin. That's also considered as eye rubbing, but both are very, very different. And young children have very commonly blepharitis, and that's why you do come across many times children having recurrent stye issues. You can have chalazion. You also have in children meibomitis related keratoconjunctivitis, where they get corneal scars and vascularization. They do not open their eyes. They like to be homebound. All such cases are related to that. They ultimately end up in evaporative dry eye. Having said that, the reparative mechanism in young children is very, very good and very, very efficient. Hence, when you treat the root cause, they do recover much better than an adult person. So I really don't go by one particular test, but holistic examination, what Hemant was referring to, is something which would be more important.
Thank you.
Sir, can I answer about Nargirkar, sir, about the vitamin A you had asked in between?
Yes.
So just, it's so sad that just last week in Dhulia, I saw a patient, both eyes bilateral, a child in fact. So just so gross vitamin D deficiency leading to total blindness. And so earlier, I remember talking to Parikshit sir almost 10 years back when I was doing my paper on the various ocular conditions in pediatric population. That time we thought that maybe now vitamin A deficiency is not so common, but still in the rural areas we do get such bad
especially
cases.
in the tribal belt.
Exactly. So it is still a matter of grave concern that even losing one child getting bilateral blind is quite tragic. And now with the allergic conjunctivitis and what Hemant has also said, that we get so many patients because of the increased screen time, it is definitely a matter of concern.
So, would you advise blanket some kind of a dosage of vitamin A to those patients? Like there may be subclinical vitamin A deficiency. With vitamin A deficiency, the one problem is that it can, if you over medicate, it can lead to hypervitaminosis. So, like, would you like to cover it up by giving a short course, or what dosages do you use, or whether you use it or not?
So is it for me, that question?
Yes.
Yeah, I think we should always err on the hypervitaminosis rather than not giving it all, because especially in Indian scenario, I wish that we should give, already it is in the immunization format. So I think it is better if we do go err on the higher side.
Yes.
Thank you.
Any other questions by anybody?
Sir, just one question, Nalgika sir. I just want to know what will be like your drug of choice to start with for a mild to moderate dry eye patient who's coming for the first time. Just what is it?
Well, for the first time, if a patient is coming to me, I used to start initially tears substitute plate, non-piezo tear substitute, along with the NSAID. But then with the NSAID, I started realizing that after a couple of weeks, 3 weeks, some people used to get SPKs, and the started looking unhealthy. So I dropped them off. That was a long time back. So now I use just a tear substitute, that's all. And that too, 3 to 4 times a day and not more than 4 times a day. If the patient cannot be compliant, then I will give him a gel at night, and then give him accessory measures, such as find out what are if there are any risk factors or medications that I can change, and ask him to use glasses, goggles outside. Ask him to wash his eyes in the night. So idea is to let the patient earn higher medication. So if he's doing well with that, after 3 weeks, it takes minimum a month's time for the patient to really get stable with the kind of treatment. So he'll check after a month's time and then escalate or go down if required.
Any choice of either a CMC, HPMC, sodium hyaluronate?
I really don't like gel and non-gel are the only two classes that I usually hold, for aqueous deficiencies. So CMC and HPMC, I do not find much of a difference as such. Is there any? Do you experience or do you have any
No, sir.
different?
Because now with this sodium hyaluronate, I think everyone is saying to start as that as the first drug. Himanshu sir,
yes.
I think for sodium hyaluronate or CMC.
Himanshu sir.
I have a little different take on this thing. There is this pretty decent amount of study with Anthony Braun's group from UK. He was pioneer in dry eye diagnostic and treatment. So AJ Braun's group had studied something called tear film ocular surface resident time of different molecules, and they studied the half-life of molecules like HPMC, molecules like sodium hyaluronate, and you'll be surprised the half-life of sodium, the thickest of lubricant was 7.5 minutes. So even if you double it, which does not happen in pharmacology, you can't double the half-life, because at the end, the molecule would not be good enough to have its action. Even if you double it, we are talking about 15 minutes a drop, right? So if somebody has waking hours, 7 hours of sleep and 17 waking hours, if we put 3 or 4 times, even sodium hyaluronate is just going to lubricate the surface for not more than 45 minutes to an hour time. So I strongly feel that when you have to use lubricant, your frequency has to be significantly high. On its own, HPMC has such a low amount of viscosity that the ocular surface resident time of half-life of HPMC is 14 seconds. Can you imagine that? Such a low ocular surface resident time. Now, many times patients are happy because they do not need it that often. And that's why when we give lubricants, they still fine 3 times, 4 times, they're fine. I would rather say, rather than giving them 3 times, 4 times throughout the day, give them a choice that during their waking hours, during their active time in their life, use them a little more often. Later on, if they don't want to use that, that's their choice. So apart from all these things, you also have to remember that the viscoelasticity of any molecule or rheological property depends upon many other things, which also includes the ambient temperature. The ambient temperature in Indian condition being such high, and especially if you are from place like Aurangabad or so, the viscosity of a molecule, like even CMC and all those things, comes down drastically when the temperature goes beyond 32 to 35 degrees Celsius. So if somebody keeps a lubricant drop outside, the viscosity is not going to be as much. So simple thing like asking them to put it in a refrigerator would improve the viscosity significantly. Adding 2 different molecules can again change, because pH can also change the viscosity. Something like Cysteine Ultra, I do not have anything for or against any molecule, but Cysteine Ultra kind of thing, they have guargum. Now, most of the industry wants to throw all these PVAs and all such kind of molecules to us because CMC has come under price control. Now, these molecules per se do not have significant viscoelasticity, but that's why they have to be combined with guargum. Now, guargum, when it's acidic, when the pH goes down, the guargum becomes liquid. It's useless. And when the pH is alkaline, that's gel. So if you are using multiple formulation, like if you have a person with microbial keratitis and given them antibiotics, most of the antibiotics require for the penetration acidic pH. So there, either antibiotic is not going to work or neither your lubricant is going to work. So there are many such things about different part of the lubricant, and I would say that whatever works in your hand is fine, but just know your molecule which you like and which you want to use.
Usually in initial cases, like early or first detected cases, if I was thinking if you use it more frequently, probably the milieu changes, the neurosensory feedback mechanism differs, and the patient may not get as much benefit. So that's why I used to start with 3 to 4 types a day, not more than that, and then probably escalate later on. But people have been using it 12 to 16 times a day, and they're good with it.
I think there is a logic there, what you said.
That's a very different perspective you have given us, Doctor.
Any more questions from the audience?
No questions.
No questions. So over to Dr. Arun.
Sorry. I thank all the speakers. It was a wonderful. And now I hand it over to Dr. Shirish Thorata, MS Secretary, to give final vote of thanks. Over to you, sir.
Thank you, madam. On behalf of MOS, I really thank Aurangabad Ophthalmic Society for giving such a wonderful webinar on much needed topic. Special thanks to all speakers for sparing their valuable time and for giving important practical tips for day-to-day practice. Thank you, Dr. Lahane sir, Dr. Varsha Nandelkar madam, Dr. Himanshu Matalia sir, Dr. M. Nishant, and Dr. Himananda Sure sir. Thanks to Dr. Aniruddha Nalji sir and Dr. Arun Architre for moderating the session. Special thank to beautiful team of Aurangabad, dashing all office bearer of Aurangabad, Dr. Vaishali madam, Dr. Swati madam, Dr. Snehal madam, and Dr. Lohia for such a wonderful opportunity. Our president, Dr. Parikshit, and Ragini madam, always a guiding force for us. I thanks to Dr. Pankaj Shah and Dr. Sapnesh Sawant for all the helps, intro people for giving a technical support, and all the viewers for active participation. Thank you.
Thank you. Thank you.
Thank you, everybody.
Thank you. Thank you for
Thank you. Good night.
Thank you so much, all speakers.
short and sweet PM.
It has been great webinar. Thank you so much.
Excellent.
Thank you so much. Good night.
Thank you.
Good night. Thank you.
Good night, everybody.
Thank you all.